Hello, this is my submission for Unit 12, Fetal Development, Monitoring and Intervention. In this presentation, we're going to be looking at how the fetus develops physically, physiologically and the sensory capabilities. We'll also be looking at different ways of imaging like Dopplers and ultrasounds, how the fundal height measurement can be useful, fetal monitoring during labour, why additional monitoring may be useful, how monitoring can lead to interventions and changes to birth plans. We'll also be looking at the screening process for chromosomal abnormalities, risk factors for miscarriage and common misconceptions, and cases where termination may be considered. Okay, so first we're going to be looking at fetal development. Fertilisation occurs when the ovum and the sperm meet. This creates the zygote. This is also known as the germinal stage. The zygote then divides, travelling down the fallopian tubes towards the uterus. When it arrives within the uterus, it is then known as blastocyst. This is where the blastocyst implants itself within the uterus and then continues to divide. By week 3, the blastocyst will then be developed into an embryo, where it will start the process of rapidly developing, where all the organs and systems within the body begin to form. Physical appearance, in between 0 and 10 weeks, this is when the basic structure of the fetus has begun. Cartilage makes up most of the limbs at this point, and then 11 to 15 weeks, this is when the bones will start to harden into bone from cartilage. The ovaries or the testes have also completed their development. Weeks 16 to 20, this is when the fetus's fingernails start to form, and they will now have their own unique fingerprint. 21 to 25 weeks, this is when the fetus will grow more and form a layer of vernix, which helps protect the fetus's skin from drying out. And then 26 weeks plus is where, from here to the end of the pregnancy, the fetus is done developing, but will start to grow stronger and bigger, ready for delivery. Okay, so physiologically, development, we have the heart first. This is 6 weeks gestation is when the first murmurs of a heartbeat can be detected. This is anywhere between 110 to 160 beats per minute. The heart first forms from 2 tubes that combine to begin the flow of blood. A couple of weeks later, the chambers of the heart develop to form the atria and the ventricles. From 9 weeks, the aorta and the pulmonary artery will develop, and then 10 weeks is when the heart is then regulated by the embryo's brain. 25 weeks is when the capillaries start to form. And then we have the brain development. To start this process, an embryo develops a neural plate. This forms the base, which forms the nervous system and the neural tube. The tube will then start to constrict and develop into three key areas: the fore, the mid and the hind. These 3 areas then subdivide and divide again, creating the different structures of the brain. And we have the main areas of the brain here in this little table. We have the cerebrum, which is the biggest part, responsible for thinking, remembering and feeling. We have the cerebellum, which is the area responsible for charge of motor control. We have the brainstem, which is the area responsible for the most vital functions like heart rate, breathing and blood pressure. We have the pituitary gland, which is the gland that releases the hormones responsible for growth, metabolism, etc. And the hypothalamus, which is the area that controls the body temperature, hunger, thirst, sleep and emotions. And then bone growth. A fetus's skeletal shape will form within the first 3 months after conception. Bones initially are made up of cartilage. A baby is born with around 270 to 300 bones, more bones than an adult. This is because bones will end up fusing together and creating one bone, which leads to them having around 206 bones by the time they are an adult. Bones go through the process of ossification, which is when the bone's tissue is created. Bones continue to develop from birth to the late teens, when their bones are done developing in length and strength. Okay, so we have sensory capabilities. We have touch. This starts with the face, which increases over time. By the 2nd trimester, it will increase throughout the body. Sight, a fetus's eyes will begin to develop from 8 weeks. From 16 weeks, a fetus can then process light that travels through the womb. Sound, a fetus doesn't start to hear until 15 weeks. By 25 weeks, they may start to respond to sounds. Smell and taste, 6 weeks is when the palate and the tongue is developing. and then at 7 weeks they will develop taster receptors. By 24 weeks the sense of smell develops. Okay, so next we're going to be looking at imaging, use of imaging within pregnancy. We have ultrasound scans external. Ultrasounds are offered routinely throughout pregnancy. This is so that they can monitor a growing fetus. An external probe is also known as a transducer. This can identify the size of a fetus, the heart rate of a fetus, the positioning of a fetus within the womb, how many fetuses are growing in the womb, the stage at which the fetus is currently at, which can help determine the due date. In the UK, pregnant people are offered 2 ultrasound scans between 11 and 14 weeks gestation and between 18 and 21 weeks. Okay, so the process, external. Before an ultrasound scan, a pregnant person is recommended to drink at least 500 millilitres of fluids around 1 or 2 hours before the appointment. This allows better visualisation for the scan. Once lying on the bed, the medical professional will then apply a lubricant to the stomach, which helps movement of the probe. The probe is then placed onto the stomach, and then sound waves are created, which are sent outwards towards the target of the scan and bounce back to the viewing monitor, which allows the medical professional to examine the fetus within the womb. Then we have internal ultrasound scans. These are also known as transvaginal ultrasounds. The internal ultrasound can identify the shape, the size, and the position of the organs within the body, like the uterus, ovaries, and the bladder. Blood flow can also be identified throughout the lower body. Cerulal length and thickness, excessive fluids in the lower part of the body, ectopic pregnancies, cysts located within the reproductive system. And then the process of an internal is almost like an external examination, but rather than it being on the stomach, a probe is inserted into the vagina, which allows the examination of the reproductive organs. Gel is used to make the process more comfortable for the pregnant person and for easier movability. These examinations shouldn't be painful but may feel uncomfortable for the pregnant person. Okay, so measuring the fundal height and its uses. Fundal height is measured by using the distance between the symphysis pubis to the uterine fundus. The uterine fundus is the area in which is the furthest from the opening of the reproductive system. It sits just above the uterus and provides protection for the fetus whilst it is also developing within the womb. And the symphysis pubis, this is a joint which sits at the bottom of the pelvic bone. It connects the left and right pubic bones together. Fundal height is tracked by a midwife throughout pregnancy to track growth, ensuring the fetus is growing accordingly to gestation. And this is an example of one of the charts that a midwife would use to track the fundal height. Okay, so the method for this examination, a pregnant person's bladder should be empty. This allows more accuracy. The abdomen will be exposed and then pressed on to identify the uterine fundus. A measuring tape is used along the stomach from the uterine fundus to the symphysis pubis. Measurement is then taken using the measuring tape. The measurement is then charted on the chart to track the growth of the fetus. Okay, fetal monitoring. We have fetal monitoring during labour. Additional monitoring may be required. This is because of pre-existing health conditions, changes in heart rate, blood pressure, or lack of oxygen, known as fetal distress. Fetal position changes, face-up, transverse, or breech, having an epidural, or a baby passing fecal matter, also known as meconium. When labour begins, a midwife will then be able to check blood pressure, pulse, and temp. They'll do a urine test. They'll check how often contractions are occurring. The pregnant person will also be offered a vaginal examination to see how dilated they are. And then baby's heart rate is also regularly monitored throughout labour, continuously through the first stage of labour, around every 15 minutes, and then after every contraction in the second stage. We also have intermittent osculation. This is also known as listening in. This is when a medical professional listens to the internal organs using medical equipment. This could be by using the Pinard stethoscope or a Doppler ultrasound. The Pinard, this is used to listen to the heartbeat of the fetus within the womb. It is used to amplify the sound of the heartbeats for the midwife to be able to listen and monitor. And then the Doppler ultrasound, this is a device that uses sound waves that bounce against the body to be able to measure the heart rate of the fetus. It's also known as a transducer and placed against the stomach to be able to listen in. We have fetal monitoring during labour. We have this one here is fetal scalp stimulation. This is the process when a medical professional will use their fingers to gently sweep around the fetus's scalp. This increases stimulation. The aim of this one is to attempt to accelerate the fetus's heart rate. This happened when a contact is made. And then we also have fetal blood sampling. This procedure includes taking a sample of blood from the fetus's scalp for analysis. This helps medical professionals identify any health concerns. It also helps medical professionals make decisions on the best route for the labour and delivery, which will then lead to ensuring a safe labour and delivery for both the pregnant person and the baby. We also have continuous cardiography, which is also known as CTG. This is used by using sound to retrieve information. It is used to monitor and measure a fetus's heart rate. They can be used throughout labour to continuously monitor, mostly when the concerns and complications are involved. And then some complications include prior health conditions such as diabetes, early labour, having a C-section, pregnancy of multiples, infections, changes to health during labour and fetal distress. We have electronic fetal monitoring, or EFM. This monitor examines the fetus's heartbeat using sound waves. A device known as a transducer is used to observe continuously. The monitor is placed on the abdomen of the pregnant person using the belts. And then this monitor will also then release a chart of the information for the midwife. These belts are also able to examine heart rate and contractions at the same time. We have telemetry. This kind of monitoring can be used on a pregnant person or a fetus, and it connects to a CTG monitor. The CTG monitor can measure the heart rate of the fetus or contractions within the womb. We have fetal scalp electrodes, or FSE. This device is attached to the scalp of the fetus during labour. It is then capable of monitoring the fetus's heart rate and health throughout labour. The fetal scalp electrode, which is here, is a device with a spiral wire at the end, which includes the electrode and then attaches to the fetus's scalp. We have intrauterine pressure catheters. This device is used to monitor the progression of contractions during labour. This is used by inserting a catheter into the uterus where it rests between the uterine wall and the fetus. This device is used to gain better clarity of measurements of the strength and frequency of contractions. It can also be used to identify key methods of support to assist with fetal delivery. Also, an IUPC is not routinely used, but it may be considered if concerns arise that further monitoring of contractions is required. Okay, so how fetal monitoring can affect birth plans. Fetal monitoring can lead to changes in a pregnant person's birth plan. This can be things like interventions. If a fetus is showing signs of distress, intervention may be used to ensure safe delivery. This can include caesarean, forceps, or the use of the ventouse suction, also known as the vacuum delivery. Medications, if the labour isn't progressing or contractions are not strong enough, medication may be used to get the labour progressing a little bit more. Oxytocin is a good example of medication for this. Changes in birthing method. Every labour is different, and if monitoring shows a fetus is struggling with a vaginal delivery, a caesarean may be recommended for a safer delivery. Additional assistance could also be offered, like the forceps and the ventouse suction. Other ways that birth plans can change are episiotomies. This is the process of a medical professional making an incision to assist in the process of pushing the fetus out. The incision is made between the vagina and the perineum. Episiotomies may be necessary if the fetus is in distress, or forceps or ventouse delivery is happening, or if there is a risk of the pregnant person tearing is higher. Inductions, this is the process of artificially bringing on labour. This can include the breaking of the waters or the use of medication. Inductions may be offered if the labour hasn't actually occurred before 41 weeks. If a pregnant person's waters have broken 24 hours prior and the labour has not started, a health condition may have been identified that could cause complications during labour, or concerns for the fetus's health has been identified. And then here is a little image of an episiotomy here. Okay, the next we're going to be looking at chromosomal abnormalities and the screening processes for those. Pregnant people are offered screening for chromosomal abnormalities between 10 and 14 weeks gestation. This is also known as a combined test, although it is up to the pregnant person to decide which conditions they would like to be screened for, or if they don't want the screening done at all. These tests include an ultrasound and a blood test being done, and then most common forms of chromosomal abnormalities include Down syndrome, or this is caused by an extra chromosome 21. Edwards syndrome is caused by an extra copy of chromosome 18, and Pato syndrome is caused by an extra chromosome 13. Okay, so the screening process. To get these tests done, the pregnant person will be asked if they want the tests doing firstly. If it is something they want, they will have an ultrasound and blood tests done. The ultrasounds will examine the fluids in the back of the neck. This is also known as the nuchal translucency ultrasound, which is the nuchal translucency showed in this ultrasound. If the pregnant person is in between 14 and 20 weeks, then they will be offered a blood test known as the quadruple test. This is only to test for Down syndrome. At 20 weeks is when screening is done for Edwards and Patos. Results will be looked at using the blood tests and the ultrasound results and compared against the pregnant person's age, weight and stage of pregnancy. Results will indicate if there is a low or high chance of the fetus having one of the abnormalities, although these are just test results and shouldn't be considered as a full diagnosis. Further testing may also be offered, known as non-invasive prenatal testing. This involves blood tests being taken and can be examined looking at the DNA fragments from the fetus's placenta. This will be used to identify the potential of the fetus having Down syndrome, Edwards or Pato syndrome. If further tests are offered to the pregnant person, they can include the quadruple test. This is done by looking at bloods, and then they look at the 4 key substances, which is alpha-fetoprotein, inhibin A, beta-human chronotrophin, and unconjugated estriol. Okay, then we have the screening for sickle cell disease. This is an inherited condition in which affects the red blood cells. It is caused by a mutation within the genes that control the body's production of the hemoglobin. If left untreated, sickle cell disease can cause serious health conditions. Screening tests are offered to the pregnant person. This test detects the sickle cell gene markings. The test is done taking bloods, which is offered before 10 weeks gestation. The earlier this test is done, the better, as more methods of assessing the fetus's chance of being affected by sickle cell disease are available, although these tests are optional for the pregnant person. Okay, so for the screening, we have if the pregnant person consents to the test being done, and both people involved in the conception can be tested, especially if the pregnant person has been identified as a carrier. If both individuals involved in conception are found to be carriers, there are several outcomes which may occur. Further testing, known as diagnostic testing, are offered, and then these tests aim to identify if the fetus also has sickle cell disease. It will also identify any other hemoglobin disorders. It will also show if the fetus is affected by any disorders or genes. Okay, so the screening process. There are 2 different types of diagnostic testing for sickle cell. We have the chorionic villus sampling, or CVS. This is a test done from 11 to 14 weeks gestation. This is performed by having a fine needle usually inserted into the pregnant person's stomach, and then it's used to take a sample of tissue from the placenta. And then we have amniocentesis. This test is done from 15 weeks and involves a fine needle inserted into the pregnant person's stomach to be able to collect a sample of the fluid surrounding the fetus. The fluid contains the fetus's cells, which then can be tested. Then we have the screening process for fetal anemia and treatment options. Fetal anemia, this is the lack of red blood cells found within the fetus's blood. This occurs through the process of isoimmunization. This happens when the fetus and the blood of the pregnant person aren't compatible with each other, although it can be caused from illnesses or genetic conditions. Fetal anemia has many risks, which can lead to long-term effects like heart failure, problems at birth if not monitored and treated correctly. The screening process for these are the amniocentesis. This is done by taking a sample of amniotic fluid using a fine needle going through the pregnant person's stomach. We have maternal blood tests, which are blood tests throughout the pregnancy to identify any antibodies or abnormal changes within the fetus's blood flow. Fetal blood tests, this involves taking blood from the umbilical cord, or Doppler ultrasounds, which will detect the blood flow using sound waves. It will also be able to detect potential heart failure. And then some treatments for fetal anemia include intrauterine fetal transfusion. This is the process of using the right blood type for the fetus through the umbilical cord. This does carry a risk of miscarriage of 1 to 3 through every 100 procedures. Premature birth is also a risk factor. Babies born with fetal anemia are usually born healthy, although they have a higher risk of developing jaundice and needing treatment within the neonatal unit. Okay, so risk factors for miscarriage, misconceptions, risks and interventions. Miscarriage information. We have miscarriage as a term used to describe the cessation of a fetus before 24 weeks. An estimated 1 in 5 pregnant people will experience a miscarriage before 12 weeks. Some known links to the risk of miscarriage include age. People who have pregnancy over the age of 30 have a 20% risk of miscarriage, and then people at 40, this risk increases to 50%. Medical conditions, lifestyle choices like drugs, tobacco, vaping, marijuana, misuse of prescription drugs, or weight problems. There's different types of miscarriages. These are the missed miscarriage. This is the type of miscarriage that occurs when the fetus stops developing but remains in the body. Sometimes this can go unnoticed and can only be diagnosed through a ultrasound. And we have a complete miscarriage. This is a type of miscarriage is when all the conception product has been expelled from the body. Or a molar pregnancy. This type of miscarriage is considered a rarer complication where the fetus doesn't develop properly within the womb due to the fertilisation of an egg which contains no genetic material. We also have ectopic pregnancies. These are a form of miscarriage when the fertilised ovum begins to develop outside of the womb. This is typically known to be unsustainable and can cause life-threatening complications for the pregnant person. Most commonly, ectopic pregnancy sit within the fallopian tubes but can also form within other areas of the body. Approximately 1 in 50 pregnancies are ectopic. Some potential risk factors that may affect the likelihood of an ectopic pregnancy include endometriosis, fertility issues, issues with fallopian tubes, previous experience of an ectopic pregnancy, or age being under 18 or over 35. Some miscarriage misconceptions include miscarriage is rare. Unfortunately, 20% of pregnancies end in miscarriage. 1 in 4 people will experience a miscarriage within their life. Stress, normal day-to-day stress cannot cause a miscarriage. Miscarriage happens quickly. Miscarriages can occur over a few days, weeks, or sometimes even months. And then birth control cannot cause miscarriage no matter how long a person is taking it. Lowering the risks of miscarriage. In many cases, miscarriage cannot be prevented. The reasons can sometimes be unknown. However, some ways to potentially lower the risk could be not smoking during pregnancy, not drinking alcohol or using illegal drugs, eating a healthy balanced diet, making attempts to avoid illnesses and infections during pregnancy like chickenpox, rubella, etc. Avoiding certain foods like unpasteurised milk and cheese, eggs with the British lion hen stamped on the shell are best, and also avoid eating cold cured meats. Medical intervention for miscarriage. Sometimes medical or surgical intervention can be an option for a person experiencing miscarriage. For medical intervention, there are two different types of medicine that can be taken to help the body to pass the pregnancy. These are mifepristone and misoprostol. The mifepristone prepares the body so that misoprostol can be more effective. The misoprostol works by causing the womb to contract and pass the remains of the pregnancy. Progesterone pessaries are also another form of medical intervention, and this is a medicine which is inserted vaginally and should take effect within a few hours. Surgical intervention. Surgical intervention may be advised for a variety of reasons, including heavy bleeding or continuous bleeding. Miscarriage becomes infected, expectant or medical management is unsuccessful. Surgical intervention involves a surgery that lasts around 15 to 30 minutes. It involves the evacuation of any retaining product. This is done by the patient being sedated and having their cervix opened. A small tube is then placed inside to remove any material from the pregnancy. Another process that can be done is manual vacuum aspiration. This involves the process of using local anaesthetic and a small tube device to remove any product from the pregnancy within the womb. Okay, we have the process of medical and surgical termination of a pregnancy. In Scotland, Wales and England, abortion can occur within the first 24 weeks gestation. In 2019, Northern Ireland also joined this. After 24 weeks, abortion must meet certain criteria to be performed, which include the pregnant person's life is in danger if the pregnancy continues, the pregnant person is at risk of harm mentally, physically, etc., or a severe abnormality within the fetus has been identified. Before a person can attend a medical or surgical termination, they must attend some appointments. This is to discuss the treatment options and to assess their health and needs. Risks will also be discussed depending on the patient's medical history, etc. The patient will also be offered a mental health help, including methods of help after the termination, and from there the patient can consent to any procedures regarding their termination decision. Medical termination. This is the process of using medication to end a pregnancy. These medications are the mifepristone and misoprostol. These medications halt the production of progesterone. These medications can cause stomach cramps and bleeding. Okay, surgical termination. We have the process of having surgical procedures done to remove a pregnancy. These procedures can be done under local anaesthetic, conscious sedation or deep sedation or general anaesthetic. These include the vacuum aspiration. This procedure is done by having a small tube inserted into the vagina towards the cervix to remove the pregnancy, or dilation and evacuation. This procedure involves the usage of forceps. They are placed into the cervix towards the womb to remove the fetus. This procedure is offered over 14 weeks gestation. And then at the end, I've just added some support for after a miscarriage or abortion. We have the different associations or care lines or websites, numbers to call for anyone experiencing abortion or miscarriages. Thank you.